We're going to go ahead and get started with our next session, which is our managed care organizations. How are we working together in a collaborative approach? So I'm going to turn it over to Monica Yanger from OACB, and she'll kick it off with everybody. Sorry, we just have it here, and then Roxanne wants it. Oh, you want that one? Yeah, she likes the one.
All right. Good afternoon. All right, we're going to try that one more time. Good afternoon. Thank you. All right. My name is Monica Yanger. I am with OACB, and you are in the Managed Care 101 session. This is the second to last session in the SSA track. So hopefully this is where you're wanting to be. Thank you for being here and taking the time to learn more about Medicaid managed care. So I am joined today by our 7 wonderful Medicaid managed care partners. And I'm so delighted that they are taking the time to be with us today and share the work that they do. They are very much here to talk with you and share how they can collaborate with you, particularly with those that are on waivers and that are very much served in our communities, and how they can be great partners with you in serving these individuals. So if this works.
It was working earlier.
That's okay. Can I just do this way?
Here we go. Next one. It's just frozen.
You know what? The next slide is just the name slide. So we can just, I will introduce them going down the line. Oh, did we get it? Oh. I'm just going to test it to be sure. There we go. It works. All right. So first off, we have Ashley Sweeney Davis with Amerihealth. Ashley, do you mind? There we go. Perfect. Thank you. We have Jenny Scott with Anthem. Brandy Hahn from Buckeye. Roxanne Richardson from Caresource. Marissa Childers from Humana. Erica Booth from Molina. And last but not least, Liz Milburn from UnitedHealthcare. And with that, I will turn it over to Roxanne to kick us off.
So I can see my slides. Good afternoon. Everybody hear me okay? We're good? Fantastic. I see so many familiar faces. It's so great to be back here. So let me just give you a quick introduction of myself, and then I'll dive into my slides. So again, Roxanne Richardson, AVP of Strategic Policy at Caresource. I've been at Caresource, I can't believe it, it'll be 2 years this summer. And prior to joining Caresource, I was the Deputy Director for Ohio Medicaid Managed Care. And prior to that, I was at the Ohio Department of Developmental Disabilities. So I probably worked with many of you at some point or another. I want to thank OACB for inviting us and having us present today. And I hope you all get a better understanding of managed care by the end of our session. So I'm going to start with a story. It feels like yesterday that I was sitting in, well, we weren't in this building, but sitting in the audience as an SSA, because I did work at the Delaware County Board of Developmental Disabilities for many years, and I was an SSA. And prior to that, I was at Richland County. So if there's Richland County here, I was there as well. But it was 23 years ago that we were at the county board, and our superintendent said, managed care is coming. And guess what? We all freaked out. We're like, oh my gosh, managed care. What's managed care? They're going to come take my job. What's my role going to be? Like, and we just didn't know. And it was just a very uncertain time. And I hope after today, we're able to express how we just want to work collaboratively with the county boards and partner with the county boards because we serve a really, really complex population, and a population that we just need to, wrap our community and wrap people around to best support the families, the individuals, and just really help these individuals live the healthiest and best lives that they can. I'm not following my slides, I'm sorry. So let me just start with just a little kind of high level of what managed care is. So essentially, managed care is simply a way of delivering healthcare services. And the Ohio Department of Medicaid contracts with managed care organizations, managed care plans, it's kind of the same term, and they contract with us. And then in turn, the department pays us for every member that is enrolled in our program. And then what we do is we coordinate the services and pay providers based off of provider contracts. That's super like high level, but that's essentially what managed care is. And this team, we're going to kind of dive into all of the facets of how we serve members, how we serve our members and the individuals collaboratively with the county boards. So in Ohio, we have nearly around 3 million individuals that are eligible for Medicaid today. And, you know, these numbers fluctuate. So, you know, this is a snapshot in time. However, of that 3.1 million, we have 2.8 million enrolled in traditional managed care program and around 140,000 enrolled in the MyCare program. And I think a lot of times people get confused between managed care and MyCare. MyCare is a program for folks that are dually eligible, meaning they're eligible for Medicare and Medicaid, some other eligibility criteria, and they live in a certain region. They are in the MyCare program. If you want more information on MyCare, Ohio Department of Medicaid has great resources out there, or feel free to chat with me or anyone after the presentation. And then that leaves roughly 213,000 enrolled in the fee-for-service program. This slide here just shows all of the populations that are served in managed care. Essentially, it's almost all of the eligibility, Medicaid eligibility groups that are enrolled. What is unique about the individuals that you all serve is that population, if they are enrolled in a home and community-based waiver, so if they're enrolled in the level 1 waiver, individual options waiver, or self waiver, they are considered a voluntary population. If you have individuals on your caseload or that you serve that are not enrolled in a home and community-based waiver, but they are eligible for Medicaid, they are one of the required populations that are enrolled in managed care. That's the biggest distinction with the population that you all serve. So what happens then when you have an individual who is enrolled in managed care and they now are offered a waiver? They enroll in the individual options waiver and they now will flip over to fee-for-service. And there was another point that I wanted to make about that as well. Also with the voluntary population, if they want to enroll in managed care and they want to select a plan and enroll in the program, they would either have to call the Medicaid hotline, and there's enrollment brokers that can help support them in selecting a plan that would best meet their needs, or they can use the Medicaid portal. Once an individual is enrolled in managed care, let's say that they're a mandatory population and they are enrolled in managed care, they will automatically be assigned a managed care plan, and their eligibility begins the first day of the month that they were determined eligible. However, even though they're already automatically assigned, they have 90 days to call and select a plan of their choice if the plan that they were automatically enrolled in is not the plan that they want to receive their healthcare services from. I think we can go to the next slide. And this slide here just shows the populations that are not enrolled in managed care. Again, those that are on a home and community-based waiver, dually eligible, we talked about that. Individuals who do not have full Medicaid eligibility, or they may just have partial Medicaid eligibility. And I think I'll turn it over to Ashley. Thank you.
All right, I think we're gonna start the trend of the panel.
Apparently I want all the attention.
Okay, so in around 2019, the Department of Medicaid went through a large re-procurement, process. And they did kind of extensive listening sessions. They gathered feedback formally, informally. They pulled, focus groups together, and they put out a bid for what they call next generation of managed care. So if you've heard that term, next gen, the department and plans, that really is kind of the updated focus, I would say, for managed care plans. The next generation program, like I said, procured in 2019. We didn't actually go live until February of 23. So what that really means is that we have some new plans within the system. So Amerihealth being one of them, and Humana being one of the other new plans for the actual managed care plans. We went live in February of 23 with membership. There were also some really other large systemic changes to the Medicaid system. So you may have heard changes around claims and provider credentialing and pharmacy benefits, right? So I just share that to kind of share that within the context of managed care for the last couple of years, there have been some pretty large structural changes. The 5 goals of the Next Gen program are around improving health and wellness of individuals, emphasizing a personalized care experience, supporting providers, improving children, care for children and adults with complex needs. And we're going to talk just a little bit about Ohio Rise a little bit later, which is one of those kind of big systemic changes in the last couple of years, and a new provider for individuals with complex health and multi-system youth. And then the last one is increasing program transparency and accountability. So I think of this as just really good operations, just clean operations. And then the kind of model of the department is this person-centric model. So on the left-hand side of this slide, the department has their kind of traditional managed care model, business-oriented, very structured guidelines. And on the right-hand side is this kind of new next-gen model where it has the person at the center and that kind of multidisciplinary team wrapping around that person. So we have all the different managed care plans. We have our Ohio Rise partners. We have our county boards. We have all of those CMEs, those care management entities in the state, our pharmacy benefits, but all really what I want to get out of this slide is that the overall goal is that the person is in the center of the plan.
Okay, thank you. I am going to start talking a little bit more about care management, care coordination, and some of the changes with that. I'm sorry. So looking at the slide, it looks more like if you want to say the first one, the previous state of care management is more like a prefab house. Everything looks the same. Everybody gets the same services. Role to get those services. Where in the new state where we're at with Next Gen, it's more of like a custom built home. So you're getting to pick some of the things that that your member needs. The member has more of a voice and a choice in what their services look like, their care coordination. And so really what that is it was Medicaid's way of making sure that we're looking at both the short-term and the long-term needs of each and every member individually. Okay. I'm sorry, I can't see the slides, so I'm looking at papers. I apologize. So care management in and of itself really hasn't changed a lot. It's really more of a way to coordinate care. we look at things as care coordination now. So there's a couple of different pieces to that, where what you want to see is the need to qualify is no longer there. But some of the goals in some of the activities are a little bit different. So as far as care manager, so it's okay. So go to where it splits. So there are a couple of different what do I want to say? People involved. Yeah. Individuals involved in the care management journey or the care coordination journey. So if you have a member with short-term, just kind of quick turnover needs, those are members that are going to get involved with a care guide. Now, in your case, your members that are involved with the managed care plans, they'll be with a Care Guide Plus. The Care Guide Plus are folks that work with the CCEs, the care coordination entities, and the care management entities. So they're doing a lot of that individual, but closing the gaps with different service providers in the community. So they really have to tie the loose ends up. So the care guide is a more quick, short-term, think SDOH needs, think maybe housing, food insecurities, that kind of thing. Think of that. And that's what those types of things are. When you get to the higher level of the care management, the care coordination journey, that might be rolled up to a person that's called a Care Manager Plus. Those folks are more of the longer term, think more of the physical health issues, or, they have more, chronic health conditions, behavioral health conditions, things that aren't just going to clear up in a matter of, a few months or so. So those Care Manager Pluses also coordinate with the CCEs, the Ohio Rise, the CMEs, and so on. You can go to the next slide. So a little bit more about the Care Manager Plus and Care Guide Plus. Like I said before, it's the care guides are the event driven. So the care guides are, and I didn't make this point. The care managers and the care guides are meant to be like a single point of contact. Medicaid recognized that all of our members are really getting a lot of contacts from a lot of different people. And so there's a lot of loose ends that just tend to get, kind of frazzled. And so trying to pull that together and having one person coordinate the care, it was their main goal here. And so that's why they, devised that care guide, Care Manager Plus and Care Guide Plus, and had that be the single point of contact. How it works for you is that, so when you have a member, okay, let me start from the beginning. So when we have members, we get a file each month to each of the MCOs that says, here are all the members that are now listed in DODD and are receiving these waiver services. So what then is going to happen is you're going to get a call or an email from that Care Manager Plus or Care Guide Plus saying, hey, I'm so-and-so from Buckeye Health Plan. That's where I'm from. And I'm here as the care coordinator for this member. How can I help? I'm hoping to be involved and really help you provide the service, coordinate the care, any of the external services that you might need, whatever it is. They will request the treatment plan. And so please understand that, when we ask for those things, when we reach out to you, it's all in this really making sure that the member is getting all of their needs met. And so it's coming from that Medicaid point of contact and really, a wraparound type service.
There are also kind of some unique arrangements that a lot of the managed care plans can have. So the Department of Medicaid allows us to delegate care coordination, delegate utilization management, coordination of benefits. And so one of those examples is what's called Partners for Kids, who is the ACO accountable care organization for the Nationwide Children's Hospital. And they cover about 34 counties, and managed care plans fully delegate care coordination activities to Partners for Kids. So it's a capitated arrangement, so they receive a certain dollar amount per member per month. And they really coordinate all that members' care. So medical, dental, vision, and there are about 325,000 kiddos in the Partners for Kids in catchment area. They work with providers individually. They contract with providers. They have about 2,100 providers in the area that they work on in the region, which really kind of touches about 73% of those 325,000 kiddos are in urban areas, and about 27% are in rural. There are other arrangements like this across the state. I'm just using PFK, Partners for Kids, as an example of one of the relationships that managed care plans have.
Excuse me. I'm just going to share a quick story about a member, Bree. She's a 13-year-old girl with developmental disabilities. She receives support from the County Board of Developmental Disability. She has a individual service plan and a service support administrator through the DD board. And she needs assistance connecting to a new pediatrician. And at the managed care organization, she has a Care Guide Plus. So through that collaborative relationship, the parent or the SSA can reach out to the Care Guide Plus at the managed care organization, and it kind of facilitate that getting that new pediatrician for that member. And so that member's needs can be met. And, again, just that collaboration piece is so very important with this relationship.
Hi, everyone. Hopefully you can hear me. Yeah, there it kicked on. First of all, I want to say thank you, Erica, for sharing the story of Bree. I think it's a great story of how all these different parts and components come together to benefit the members. And another thing is we talk about this next generation model. There's a lot of changes that's happened, but one of the big things coming out of this model is that collaboration and cooperation so that we're aligning care with shared members. That way we are not duplicating efforts, that we're actually supporting you guys in the work you do, that we can be that supplement, and we're not, I'm going to say, stepping on each other's toes, working with members so we can collaborate. And one of the really neat things about that is our new care coordination portal. So the role of the portal is to help support those collaborations that we have with our care coordination entities. And what that portal does, I want to make sure the slide changes. I can barely see it from here. So you can see member level data. So you can request to any of the MCOs sitting up here. We all have a portal. They all look a little different, but they all have a similar content. And so what you see up here is the similar content across the portals. Demographics of membership, the Care Manager Plus or Care Guide Plus that is assigned to that member, the risk level based upon our risk stratification models. If we have a health risk assessment or HRA on file, if there's an MCO assessment on file, you'll be able to view it on this portal, as well as EPSDT care gaps. Those types of things are available, authorizations, claims, and the full care team that's working with the member. So there's a lot of great information in these portals that can help collaborate and align care. And the next couple of slides, they're going to look kind of the same. This is how to request access to the different MCOs for how to get access to our portals. Since we each have one, like I said, they're a little bit different. They look a little different, but the same content. And the next slide shows the same. And it's really hard to see. There's a little Excel spreadsheet that we've included. Hopefully the links will work. If not, just reach out to one of the plans. We can help you with it. But the Excel spreadsheet shows you the type of information that you'll need to submit to us so that we can grant you access to view your assigned members. And I'm going to hand it over to Jenny to talk a little bit more about the process.
Okay. Good afternoon. I'm going to stand. So what Marissa was stating about the care coordination portal, and it's really that number one piece for collaboration. We talked about the next gen. What does that really look like? We heard Bree's story. When you think about Bree's story, you think about all of the members and the patients and the clients that you all work with. the number one piece of this portal is for you get to view in on us. My last role, I was the DON for the city of Cincinnati, and I had 6 FQHCs. But my whole background has been managed care. What I always heard the provider state is, Jenny, we don't know nothing about the insurance. We don't know nothing about that. So now you get the final chance to see what is going on. What is the grievances? Are you working with a client? They ask you about medications, or you want to hear about a claim and things that you really don't want to talk to them about, but now you get access to it. It's like, it looks like that was approved. So these are one of the things that you want to really utilize this care coordination portal. But I am going to ask this one question. Has anyone in the room utilized any of our care coordination portals? No. I'm going to challenge you all. You're going to receive this deck and you're going to click on there and you can just reach out to any of us. My team has access and they will take you and walk you through it. If you would like to have your entire team trained, we can do that also. But I will challenge you to do that because our number one goal is for collaboration. We hear this often. My managers say, well, Jenny, they feel like they don't need to work with us and we're trying to do this together. So this is what this care coordination portal is for. So when you see a screen here, the number one thing is to receive your OHID, and how you do that is you click on and you click create OHID. The number one goal here will save you time if you have that OHID, and then reach out to your MCO and their portal administrator. Once they have that, the next slide will take you into a single sign-on. So what this will show you is all 7 of our plans have access, but you don't have to go in and out. You go sign in one time. And long as you have access, you talk to that administrator, you will see all 7 tabs up there. Because we understand, and we heard this because I thought about it also. I'm like, wait a minute. So everyone would have to go into 7 different portals? So I get it, because I know you're like, well, I have 10 with this person. I have 100 with Caresource. And I have, Jenny, you told me that I have 5 with you. But the key here is we want to make sure that if you're working with Bree and Bree's mom is like, I really need help with getting diapers, or I really need help with this. I don't know anything about these value-added benefits, because all of our value-added benefits are different. Just to tell you, they're all different. So the key here is if I reach out to that plus role, she's going to say, hey, here it is. And sometimes you can just go in there and find it yourself, because what we're starting to notice is we're receiving emails from things that you wouldn't have to wait on the email. You're like, oh man, I emailed this care manager, I emailed the manager. No one's returning my call. But if you had access to our portal, you can go right in there and you can see that level of information at that time. So I will challenge you all to do that. It is really huge. It was also one of the requirements, as Ms. Marissa just stated, that we were required to stand these portals up. Now, as Anthem, we probably had roughly around 35,000 since go live of interactions. Well, I'm not even gonna call it interactions. I'm gonna say logins. I'm gonna take that back. I wish I had 35,000 interactions. So what I'm asking for is, when we see you log in, I'm like, ask her the question, just ask the question. So I'm waiting for one of you all to send one of my plus roles a question and say, Jenny, she did not answer me. So with that being said, I'm gonna hand it over to Liz.
Yeah, good afternoon. I'm Liz Milburn with UnitedHealthcare. And just before I start, just want to thank all of you. It takes a village to manage a lot of our members, and really a collaborative effort. And so being on this panel and then seeing you guys, I mean, makes my heart feel heavy today about what we do. So briefly, I'm going to be talking about the managed care benefits. We cover both primary and acute care benefits, and you can see on the screen services that are covered. Inpatient hospitalizations, behavioral health services, private duty nursing. But you guys can go through and read these slides when you get them of the services that are offered. Next slide, please. These are some other managed care value-added benefits too as well, but I just want to point out we do offer 24-hour nurse line hotlines and also crisis service benefits too as well for members. There's a toll-free member service hotline, office hours that are extended, grievance resolutions, online searchable provider directories, and then additional expanded benefits that I'll go over in the next 2 slides. I suggest highly to everybody to print out, and we included the links for the transportation resource guide. All of the managed care plans have different protocols with regards to transportation. So print these out, and then you could just, it's a nice little grid. And when you see who's, what managed care company you're member is enrolled in, you can see what the benefits are and who to contact. Next slide. And these are also value-added benefits, which I suggest for you all to print out, add them into your binder, the services that they offer. But just in general, I mean, we have dental services, vision services, health and wellness services, strength and well-being, prenatal services, online portals again, telehealth, and 24-hour medical advice. So they're nice grids, and you could just go down the grid, whatever managed healthcare company the member has.
So I get to share another story, which is really cool. So this is a story about Frank. Frank is a 65-year-old with multiple chronic conditions. He does have a MCO care management program referral due to an inpatient hospital stay for a recent stroke. So the MCO-CM did an initial assessment and determined that he was not seeing his providers and his home was unsafe due to pest infestation and being unkempt. So the care plan or the managed care organization CM did visit Frank in the hospital. She helped facilitate a rehab stay and home health care once the member was released from the hospital. Also, a wheelchair and a bedside commode was the case manager helped facilitate during that hospital visit. The care manager collaborated with the Madison County Board of DD's caseworker via phone, secure email, and also introduced the SSA to the care coordination portal. The SSA arranged for the house cleaning, furniture, and refrigerator replacements, and coordinated via SEOH referrals to get other services carried out prior to discharge from the member's stay in the rehab facility, and also assisted with getting a provider assigned to the member. So he was able to go to his appointments, was able to facilitate transportation, and the care manager, develop that ongoing relationship with that member.
So we're almost the end. Almost the end. Is this on? You hear me? Is it on? Okay. So just to say, ODM has, the Department of Medicaid has put out guidance on best ways to collaborate between Medicaid managed care organizations and the county boards. So I believe in SSA today, we sent out a similar document maybe a year ago or so. And this one is the most recent version of the document. It was mostly updated in October, which is a grid version versus the narrative version that was available previously. So again, highly encourage you to print this out and take a look at it. It'll identify areas where best collaboration. It will describe, care plans. Of course, what a managed care calls a care plan, what a county board calls a care plan. So it actually does a really good job of also putting the language together and defining what those things are. And so you can see how managed care defines something and what that means in the role that you play in a member's life and care. Last success story. Sure.
I think this is our final slide, and then we'll go into some Q&A. So I'm going to share this member success story. The Ohio Department of Medicaid notified Caresource that we had an individual with complex needs that was going from the fee-for-service Medicaid program and enrolling in managed care. The patient, the individual was a patient at Nationwide Children's Hospital for an extended stay, a patient for about 11 months. This individual was previously receiving services through the county board. So county board has, been involved for many years. But the individual had an accident, and she had her leg amputated because of the accident. And she also had complex behavioral health needs as well. So you're talking about a minor under the age of 18, comorbidity, having behavioral health needs, as well as, complex care needs. So she needed to be discharged from the hospital. And the entire care team, including those at Caresource and the county board SSA and others involved, pretty much went through every resource in the state of Ohio to try to find a transition and a placement for this member. And because of the complexities, and we all know this, I remember being at a county board and we would try to find placement, and it's challenging. It is very challenging. So they exhausted all of their resources in the state of Ohio. And it was determined that her needs would be best met at an out-of-state placement. Never ideal, and we get that. We want to keep the kids home and we want to keep them close to family. But in order to really care for her behavioral health needs and her intense rehabilitation from the accident, it was determined that she would be best served out of state. So we worked with the provider that the team was able to secure. We developed what's called a single case agreement. So not all providers are in our network, but you can request for a single case agreement so that we can pay that provider and have a quote unquote contract. We quickly developed a single case agreement and quickly processed the prior authorizations and got it approved for her to receive services at this inpatient facility. I don't know how long she was there. I'm sorry. Oh, there it is, 5 months. So she was at this facility for 5 months to get treatment. We also arranged for the family to be able to go see their child weekly. And then in order to transport her, this is important too, in order to transport her, because of her behavioral health needs, she had a hard time just sitting still at that attention. And because of her physical needs with the amputation, it was determined that it was medically necessary. You'll hear that term often with managed care. It was medically necessary to do a med flight. And so we processed the prior authorizations, did a med flight. It was the safest and most appropriate way to transport her. She did fantastic. She had a great treatment plan there. And when it was time for her to come home, the SSA worked with the team, and the service and support administrator was able to secure kind of a transition placement here back in Ohio. And it really was a truly collaborative, there's a fruit fly or something. It really was a collaborative team effort to serve this individual, and not just the individual, but the family. And so, the end of story, she's back here in Ohio and continuing to receive services. That's all. You want that back?
So thank you. I mean, I hope this helped at least. I hope this is informational. Number one, that's a great idea to challenge folks to, for those of you who have individuals that are in managed care, to look up the portal, like maybe create an Ohio ID. It sounds very scary. Yes, me. I'll create an Ohio ID and go to the portal and create an opportunity to engage with the managed care plan on behalf of your individual. So I do have, I left my notes over here. I do have a couple of quick FAQs, and then we'll open it up to the audience for some additional questions if you have any. So first one is, what are the most popular benefits that individuals should be aware of?
I can kick that one off, and my cohorts up here can jump in with anything additional. So when you're looking at popular benefits, MCO benefits, we do cover ABA services. So definitely that is something I think should be known, that folks know about. In addition, EPSDT and those special DMEs, special services, those are also pretty popular benefits that we offer, as well as DME items. Health check, wellness. I think we've mentioned there's some wellness incentives that's attached to well baby checks, annual exams, those flu shots. There's a lot of benefits out there within that value added benefit package that Liz just covered. It's all in that nice sheet that she included. Also, our value added benefits, non-emergency transportation. There's also a non-emergency transportation benefit that maybe can give a ride to someone to the grocery store or something like that as well. So it's not necessarily only limited to medical, dental or vision appointments. There's some other things in there. And in addition, I'm, really glad the challenge for the care coordination portal, because that is a great way to connect with us to see these types of benefits. But in addition, I want to say we all also have public facing websites. You can just Google the name, Google us, this will come up. And there's in there, you can see all these same things. There's also member handbook samples in there in case one of your members needs a new handbook. There's some additionally release of information forms that we may need for different things. So there's lots of information on those public facing websites. I want to make sure to put that out there. And that's the most up to date. That's where the updates come through. So it's another great resource. In addition, I just want to call out, I have a couple of my Humana associates out here who I think are going to get really busy, thanks to you, Jenny, because they do CCP access, our care coordination portal access. In addition, they also support our DODD members and doing connections with the boards to coordinate care. So Jen and Sandy, and they're here, so feel free to ask them questions around the portal. They do a lot of the training as well, but I know they're thinking, oh no, a bunch of emails coming, but that'll be great. That'll be great.
Thanks, Marissa. How often can a person switch plans?
I'll start off. Every year there's something called open enrollment. Is it work? Okay. Runs typically from November 1st to November 30th. And, if someone's with one managed care organization and wishes to switch to another managed care organization, they can do it during that open enrollment time. You'll probably see lots of commercials on TV and lots of radio ads and lots of billboards and stuff during that time. To try to, have people enroll into the different plans. So that's kind of like the stock answer for the yearly switch in benefits. But I know there's a couple of the other special occasions when people may switch as well.
Yeah, that's fantastic. And I'll just add to that. One of the differences for the voluntary population, so those that are on a home and community-based waiver, the voluntary population, they are able to switch plans at any time throughout the year. While we don't recommend it, right, because you want continuity of care. If for some reason that, the services that they're receiving from a plan is just not meeting their needs, they certainly can change at any time by contacting the Medicaid hotline and requesting that change. Another thing that I will add as well, if a person is not able to access a provider or there's some other circumstance, happening with that individual, they can call the Medicaid hotline and request to change plans for what we call quote unquote just cause reasons. And so they would just have to provide, that detail, that information, and that'll be reviewed to determine if they're able to switch outside of the open enrollment period.
Thank you. What happens if an individual managed care goes to an ICF?
I'll take that one as well. So if an individual moves into an intermediate care facility and they are going to be in that facility for long-term services, they will be disenrolled from managed care. And then once they exit or transition out of the ICF, they can enroll back into managed care. Now, if they are going to an intermediate care facility for short-term, maybe some respite services, they will stay enrolled in their managed care plan.
Thanks. Finally, how do you work with Ohio Rise? Can you say a little bit about that?
So I'm sure that there's plenty of you out there that have had experience with Ohio Rise. While I don't know, what is it like? They're still building up. So it's kind of like, plane while it's in the air, kind of thing. So what I can say is that there are several different ways for a member to become eligible for the Ohio Rise program. But what the biggest thing is that what we want to do is make sure that that member has their linkage to their CME, whether it, depending on the tier that they're in after the CANS is done. So there's 3 tiers, there's tier 1, 2, and 3. If they're with tier 1 and say they're with Buckeye, I'll just stay with where I'm at. What would happen then is that they would have a care coordinator with Aetna. Aetna would take over their behavioral health case management, care coordination, and then they would continue providing those services to that member. When there's a physical health need or another need that falls outside of behavioral health, those would come to Buckeye to cover. So we really want to make sure that we're having those child and family team meetings to make sure that it really is that wraparound type service. Tier 2 then and tier 3 are higher levels of care, and those would be sent out to the county that has the CME in the county that they're in. So there are how many CMEs? 19, I think 19 CMEs, and they're each based in different regions of Ohio. As far as Buckeye is concerned, we have care manager pluses and care guide pluses that are assigned to work with each of those CMEs, so that there's that established coordination of care effort and that everybody has that communication. And again, while I say, it is still new, it's going on this year 2. We are really working hard on making sure those transitions of care are clean, that, we have those warm handoffs as much as possible, and that we're able to procure the services that the members need. Without getting too in the weeds with it, that's kind of high level what it looks like when a member is in the Ohio Rise program. What it goes as far as a member that is working with DODD, we also need the input from the SSA as far as, some of maybe the things that are on the treatment plan. So inviting you all to the family care team meeting is very important, to have that place at the table and make sure that, you're advocating for those different needs as well. Because 9 times out of 10, you're the ones that know those members, and have that more rapport with the family, the guardian, the member, and so on. So it's really it's a very tight wraparound situation. Again, there are a lot of moving parts and pieces, so we really need to make sure that we have the right folks at the table.
Great, thank you.
But asked Aetna, and I've gotten their response on this, but I would like to hear it from your guys' perspective. So we've had incidents where families have declined or they would like to decline services through Ohio Rise. And the response I received is that if they do that their behavioral health care would still be covered by their original managed care organization. Is that accurate, that if they decline Ohio Rise, and so they're declining Aetna, would, say, Buckeye continue to cover their behavioral health care?
So if they're eligible through a CANS assessment and they're rated at a tier 1, 2, or 3, it is a mandatory thing. They are in that. They're in Aetna. Now they can go through ODM and say, hey, these services are not for us. However, it really is a good, as long as you have that family care team meeting, tight-knit wraparound services. Each individual situation is different. So, but yes, it is a mandatory thing. It's not something that it's not very easy to back out of. The one thing I can tell you is that they can switch CMEs if they 2 or a level 3, they can switch from one CME to a different. That has to go through a process. So
I'm gonna switch you. You're starting to go in and out
Yeah.
too much. See if that works.
So what you would want to do then is contact your managed care if you have a good rapport with the managed care, either the Care Guide Plus or the Care Manager Plus, and they can help walk you through that.
Are we good for some more questions? It's like they got, okay. All right. See if that one's working for us.
What can an SSA do if an individual has no idea who their managed care company is? And then how does this all coordinate with Medicare Part D as well?
Sure, that's a really easy answer to question or question to answer, right?
So I think the question was, how do they know, I'm sorry, who their managed care organization is that
If
they're
they don't
enrolled?
know, what's the best way?
Sure. I mean, you can always call the Medicaid hotline and give them their, name, date of birth, et cetera, and they can always look it up on the Medicaid hotline. You can probably try to find it on the portal. If they have a card, it should be on their Medicaid managed care card as well. But if they can't even find a card, just have them call the hotline.
And then she was asking how it works with Medicare D. Do we know that answer or is?
I don't know if I can fully answer the Medicare Part D question.
We might need to put that down in the more information coming. Way to go. Way to keep us on our toes. Thank you. All right, are we opening it up to any other questions? We got some more? All right. I knew you guys would take care of us here.
I kind of have a specific question. I have an individual right now that had just received a waiver for home and community-based services in February, and they are under Buckeye for managed care for the month of March. Well, the residential provider is not being paid because they're being told by Medicaid that they need to bill the managed care organization for those services. How do I get out of this rabbit hole?
Obviously a very specific question, but
is to have the provider call the provider services line and find out what's going on with that. There's a specific number for that. I don't know it off the top of my head. I apologize. But if you go to the Buckeye Health Plan site, you can get right into there. There's a lot of information on that for providers. So that's the best way I can say to get into that.
We can probably talk offline on that one.
yeah, come see Monica, not me. Monica. Every time somebody says managed care, I go like this. So, all right, more questions, right? All right, come on. Oh, there we go. See, they only need a little taunting. No, you can't. I'll get yelled at. Everybody's like, no, everybody thinks they're loud.
What is the SDOH that the SSA referred Frank to clean his home and replace the furniture in the refrigerator? Does everybody know this but me? It was in the story about Frank that his caseworker referred him to SDOH for home
So if you're asking
cleaning.
what SDOH means, that's social determinants of health.
Yeah.
Yes, housing, electricity, food insecurities, those kind of things.
Is that through the managed care plan?
So I can speak to Buckeye. We do have a team that does address SDOH needs. Yes.
Awesome. Thank you.
Some of the, also can I just real quick, next gen model really moves towards what is called a population health model. So all the plans really should be looking at social drivers of health, social determinants of health, food security, housing, put education. We've got metrics on all of those things, making sure that we're addressing those really structural needs of members. So that also kind of shifted with the program shift as well.
I would also add that it's very imperative if you all can help us with that HRA, because majority of the questions on the HRA are those SDOH questions.
What is HRA?
That is your health risk assessment. It needs to be done every year by every single one of anyone you touch. We need assistance with that. And that is something that you can also see within the portal. If you look into the care coordination portal, whether or not it's done, or you could even ask them. And even if they didn't want to go into a portal, you can, majority of all of us have either an app or we have the member portal. They can go on the portal and they can also complete that, or you all can assist them with that also.
And what that is a standard set of questions that helps managed care plans understand what needs members have. So for example, one of the social determinants that we just talked about was food security. There are 2 questions about food security on that health risk assessment. You know, do you have enough, I think it's around, do you have enough food to make it through X amount of time? Do you have to, ever give up food to buy your medicine, that type of thing. So it really helps the care management team understand where their members are.
And I just want to add, it's really brief. I know you think large assessments, lots of questions. It's really just a handful of questions. So it's really quick for someone to complete.
Awesome. Another question? Yeah, that was a great question. All right, one more we got time for. Let's see what we got. Is that Devin? Devin always has great questions.
So for managed care plans, you had said that if someone is admitted into an ICF, that they wouldn't maintain eligibility. But if there was a short-term stay, so like if we have like a transition, like multi-system youth, like is there a period of time for an ICF stay that they cut them off?
Good job. All right. I see lots of people looking. I think this might be a follow-up.
Love to get back to you on that one.
Yeah, I mean, that's a great question for the Ohio Department of Medicaid, for sure, to be able to respond to that. And I'm no longer.
All right. She's. All right. Absolutely. Yeah. Let us know, especially as that comes up for somebody. Well, that's how we find out. All right. Well, it is 3:43. I think we're going to give a hand to our panel. Thank you so much.